everyone. Welcome to the Concussion Discussion Series brought to you by Integrated Brain Centers. I am your host, Amy Zellmer from Faces of TBI. And today I'm excited to introduce you to Shauna Hahn from Framework TMS. And today she's going to be talking about surviving common mood problems after a TBI. So welcome, Shauna. So excited to talk about this today.
Thank you. Hello from Lake Oswego, Oregon. So I'm not sure where we want to start. This is an overwhelming topic.
It is. It's a huge topic.
So what I'll do is give a little bit of background that we absolutely know this is a thing. And I'm going to address three major kind of studies. One is going to be the Danish study, excuse me. Then we are going to move on to the Redelmeyer study and then finish off talking about something called the default mode network, which we know is disrupted in both brain injury and in depression, anxiety, and post-traumatic stress disorder. So let me start by saying that the Danish study, it was a huge national registry study that was followed participants who were born in 1977 to 2000, and they followed them up until 2010. This is 1.4 million people, so it's a very important public health study. Of that number, 114,000 suffered brain injuries, okay? And they followed them to see if they were at enhanced risk for having a mood disorder or a psychiatric illness after their injury. And of course, the answer was an overwhelming yes. When we looked at the increased risk for depression, it was a 59% increased risk, which correlates with some other research we know from Fan et al. I won't mention all those authors, but that said that at least 67% of people with brain injuries end up having depression following a brain injury. And this compares to the regular population, which has only an incidence of about 10% depression in any given year, like for the rest of us. Back to the Danish study, 28% increased risk for bipolar disorder, 65% increased risk for schizophrenia, and 420 something % increase for something called organic mental disorder, which is what we might also lump into what we call post-concussion syndrome, right? And this mixed cognitive, mood, and other syndrome that happens. But sometimes that term can be so insulting to people because it really undermines the depth and severity of people's symptoms. So the author of this study was like, I had expected to see a correlation between having a brain injury and having a subsequent mood disorder, but nothing on the scale that they ended up seeing.
Yeah, wow. And I mean, those of us watching aren't probably all that surprised, but yeah, it's validating to hear those numbers.
Absolutely. And what they did when they talk about increased risk, this compared people who had been admitted to the emergency department with any other illness. If you'd gone in and broken a toe, we are comparing your toe break and following you over time compared to somebody who had a brain injury. Okay. Wow. And in fact, interestingly enough, not that I'm a broken toe proponent or advocate in any way, but you're actually more likely to end up being mentally ill if you present to the emergency department, even with a broken toe.
Interesting.
Very interesting. So let's skip forward to the Redelmeyer study. Donald Redelmeyer works out of Sunnybrook Hospital in Toronto, and he published a study on the increased risk of suicide following brain injury. And he discovered that having a brain injury triples the risk of suicide. So on average, at least in Canada, 9 out of 100,000 people commit suicide every year. When we look at a brain injured population, that number increases to 31 out of 100,000 people.
Wow.
It's tragic. Interestingly, the greatest risk period is not in that initial 6 months of the injury. The greatest risk occurs 6 to 15 years after an injury.
Wow, that actually surprises me. I thought you were going to say 6 to 15 months.
No, what ends up
Wow.
happening, Amy, and you and I know this,
Yeah.
that our patients experience such invalidation.
Yeah.
So they are maligned as being malingerers. They are maligned as being lazy or developing a character flaw. They start to lose friends. They lose spouses. They lose jobs. They become alienated and detached from their families, right? And all of these things end up in this accelerating course because trauma and depression have a way against work against any possible sources of support for us.
Mm-hmm.
And brain injuries with the sensory overwhelmedness, the poor tolerance for activity, the scrambled thought process, poor memory, it all just kind of adds on top of one another.
Yeah. And not to mention 6 to 15 years of probably not getting proper treatment, right? Yeah.
That is absolutely correct. In fact, so there are two separate statistics from the Redelmeyer study. One is that if you experienced a weekday injury, the incidence of suicide is only 29 out of 100,000. Okay. Remember, I said that the overall risk was 31 out of 100,000. If you have a weekend injury, you are actually more likely to commit suicide. Your risk goes up to 39 out of 100,000.
Do they have a reasoning for that?
Yeah. So if you think about it, if you're having a weekday injury, you are more likely to be at work. And at work, we have all these precautions and things we do if people get injured at the workplace. We're like, okay, you need to go get evaluated. And people get better follow-up care, which is just so astute that, what you said earlier about people not getting proper care. Versus the people on the weekend who are more likely to minimize, who are less likely to get follow-up. They're just kind of like, I'm going to shake this off. These are recreational injuries. These are people who experience household injuries. I went up to clean up the gutter and fell off my ladder. I'm just going to go take a nap now, right?
Yeah.
And then they end up with this neuroinflammatory process and all of the stuff that we know that goes with this terrible sequelae to having a brain injury.
Wow.
And the problem also is that people in positions like mine, they don't go, oh gosh, you're presenting to me as being depressed and suicidal.
No.
Did you have a brain injury 6 to 15 years ago?
Right.
We are not asking that. And often people are, again, minimizing this. They're minimizing the impact. We often have to do some digging to hear about people's lifetime incidence of brain injuries.
So true.
Because it is a cumulative effect. So point number 3. So, one of the modalities we offer here, and I think that this is such an important modality to share because we just keep seeing its success over and over again. And you don't have to come to Framework TMS. You don't have to come to Northwest Functional Neurology to possibly access care for yourself wherever you live in this country. And that is TMS, or transcranial magnetic stimulation. And it is such a powerful modality. It's considered non-invasive neuromodulation. It's an extremely harmless way of affecting great brain changes, okay? And I know that most of us are going to benefit because when we look at the circuitry, the brain networks that get disrupted in brain injury, they're exactly the same as the brain networks that get disrupted in depression. Okay, there is something called the default mode network. This is the resting state of our consciousness. This is what our brain looks like at rest. Okay, this is our autobiographical sense of self. This is all of us, what we understand about our traits, characteristics, memories, life events, our social network. I always like to say, when you wake up in the morning and you're looking at the ceiling fan or looking outside at the clouds, you have a sense of who you are, what your day's going to look like, what you dreamed about, right? This is all non-focused kind of usness. So we have this default mode network, and we have, I was going to make placards so I could arrange this. We have also something, so the default mode network, let me just backtrack a little bit, is comprised of structures like the posterior cingulate cortex and the ventromedial prefrontal cortex, okay? In the middle, we have something called the salience network. So the word salience means our important noticing, and the salience is a broad network connecting a lot of structures in our brain. And it's comprised of the anterior cingulate, the substantia nigra of the ventral tegmental area, something else. This striatum, sorry, I knew it would come to me. And what happens in depression? And we have this third circuit called the executive network. This is us being on task, problem solving, attention, sustained focus, right? This is us getting stuff done. This is us at work. This is us following a recipe, right?
Yeah.
But anybody who's ever been depressed or had a brain injury knows that what ends up happening is the salience network no longer helps connect us. If we have to pull ourselves back from that dream state of who we are to our attention and focus, we're unable to do that. Instead, that salience network is overly emphasizing negative aspects about ourselves. It is overemphasizing painful memories, painful character defects. It is overemphasizing feelings of despair, anxiety, sadness, right? And it is not automatically flipping us so neatly over into control executive network. So we can't often think or remember or do the things we want to do. So TMS has a way of lighting up particular structures in that executive network. So our dorsolateral prefrontal cortex, that is the common site of TMS. And even if you don't come here, this is if you go to a TMS center, that is where they're going to treat you. And the posterior parietal cortex. It also helps us light up the parts of the salience network that are helping us get more easily to that executive network. The anterior insula, it's helping us, oh gosh, I just lost my train of thought. I am so sorry. Anterior insula and also that amygdala activation is helping shut that off. And that's often what leads us to that fear-based aspect of that default mode network. So we know the default mode network is a problem for people with brain injury. Yeah. And this has been well established in the medical literature, particularly in two articles I always like to point out are both from 2012, the Journal of Neuroimaging and the Journal of Radiology both said that this is a hotspot in brain injury. Our folks suffer so much, again, with mental disorders following brain injury. This scrambled brain process that sometimes makes it difficult for them to find appropriate care and to follow and to manage our kind of disjointed healthcare system where they are trying to access a lot of different providers to reestablish wellness. I think TMS could be a very early step somebody might take to help get some of that clarity. With TMS, we are turning on the genetic response to that dorsolateral prefrontal cortex, which is part of that executive network, so that it learns to fire on its own. As well, we are increasing something called brain-derived neurotropic factor, which is like our brain's fertilizer, right? When we exercise, learn something new, we are increasing this wonderful substance of BDNF. And as well, we are increasing endogenous GABA. And just a reminder that when we have persistent neuroinflammation or we have a brain injury, we end up with glutamate, which is an excitatory neurotransmitter. We end up with glutamate excitotoxicity. So this increase in GABA can do a really wonderful job of helping combat that excessive glutamate response.
And you work in partnership with Dr. Zielinski at Northwest Functional Neurology. And I find it just fascinating that your integration with using TMS in conjunction with functional neurology and the results that you guys have. Talk a little bit about that and the results that you see with these patients.
Oh my gosh, absolutely. So I wish I had more data to share in terms of what we follow up. You know, a lot of people come here for our neurorescue therapy, which is a week. Sometimes people end up staying longer. During that time, we provide 10 sessions of TMS, which we integrate into their already established functional neurology rehab. And so we're following metrics related to post-traumatic stress disorder, generalized anxiety disorder, major depression, but also Rivermead concussion index or concussion survey and the post-concussion index, right? So we are starting to manage all of this data and talk to us in a year because it's very promising. But I want to share like this recent, I mean, we have so many, we've treated 180 patients using this integrated method, right? So we have a lot of anecdotes, if not the hard data. But just recently we had a patient who was working with one of our fine physicians here, and she was getting actually right-sided treatment of TMS. And we learned to do that through the findings that we discovered on our intensive discovery process, where we spend 3 hours doing a variety of vestibular integration testing to see where they're at. And she was not that typical left-sided treatment that I mentioned that many people could profit from. So we were treating her on the right side, helping treat a measure of something called anti-saccades. So anti-saccades are just like one of these direct measurements of how we know your frontal lobe is working. Anti-saccades are when we ask you, we pull up a target, usually a thumb, and we're like, look away, right? And a lot of times people with brain injuries just cannot. We're like, when we pull the thumb up, look away from the thumb. And they're like, my frontal lobe doesn't work well enough to stop me from doing that, because that is the governance of this wonderful frontal lobe. It is the seat of inhibition and judgment. So when we do that, you know, 1/4 of the time they can't look away. 9 out of 10 times they can't look away. And so in her case, they hadn't been doing any work to help her with anti-saccades. They had been working on other things during her week here. And at the end of the week, while we were reviewing her incredible progress, which was essentially a 70% global reduction in all the things that we measure, when we were going through this review, her doctor revealed that they hadn't done anything to help improve her anti-saccades over the week, that they'd been focusing on other things. So her improvement in anti-saccade error rate, which is like 60%, went all the way down to under 10%.
Wow.
And that was simply based on the strength of the functional TMS work that we were doing with her.
That's so amazing. I love hearing stories like that.
Oh my gosh, absolutely. And so one of the other patient stories, because I know people cotton to these stories, people love a good story.
Yeah.
Was actually a person with an acquired brain injury. And she had had a double-sided cerebral basal artery stroke, which the fact that she survived is nothing short of miraculous. In her case, we also did a right-sided treatment. And there's nothing specific to this right-sided treatment, folks. This just happens to be the case for these 2 patients that I'm identifying. And we had been unable to rehabilitate some key aspects. Her anti-saccade rate, the measure of how well that frontal lobe was doing, was 93%. She was a 67-year-old woman, which we know, unfortunately, the rehabilitative success goes down the older we are. And that's just a sad fact of brain aging. Right? So we're just giving it our best. treating her on the right side. At the end of 10 treatments over the course of a week, and this was her third week here, so I don't want to overpromise people. This was her third week here and her final week. We got that anti-saccade error rating down to 4%.
Wow.
I can tell you, Amy, my own personal anti-saccade error rate is no freaking 4%. That is like a genius rate. Genius. So yeah, and again, you know, in terms of just our overall mood symptoms, we know with depression, with classical treatment of depression, 1 in 2 of our patients achieves remission, and about probably 92 to 98% of our patients achieve response. So yeah,
that's huge.
Go get at it. Go check out your local TMS center. I really think that they can help. They can help you.
Awesome. And if anyone is interested in connecting with you, they can go to frameworktms.com and they can get in touch with you, and you offer a 15-minute consultation.
Absolutely. I'll be happy to get you scheduled, and I will definitely call you back or email, whatever your preference is.
Awesome. And again, the website link will be below this video for you all watching. And also be sure to follow on Instagram, Framework TMS. So drop us a comment below. Let us know what you took away from the session today. We'd love to hear from you. And be sure to click that subscribe button so you don't miss any of this series. Thank you again, Shauna, for being here. Always such a pleasure to chat with you.
Thank you for having me, Amy. Please be well.